that, is there Arishta starting the event live of 3 posters? Arishta?
Yes, sir. I'm just mailing the PPT to myself.
I have mailed you JPG image of the same.
That's done. Also, Praveen sir, please enable the chats.
I think we can go live, and Praveen sir, can we go live and then maybe intermittently we can put that screen?
Praveen sir.
Yes, sir. So YouTube live is on, huh? You may start session.
Yes, Simran, please introduce our speakers and let's move with the event. Welcome all.
Okay, so a very good morning to everyone. I am Simran Jambia, psychological counselor at SKU, and I would like to thank everyone for joining us today on this webinar on bipolar disorder. World Bipolar Day is observed on March 30 every year, on the birthday of Dutch post-impressionist painter Vincent van Gogh, one of the most influential artists in the history of Western art. The vision of World Bipolar Day is to bring awareness to bipolar disorders and to eliminate social stigma. The goal of World Bipolar Day is to bring evidence-based information about bipolar disorders that will educate and improve sensitivity towards the illness. Now, living with bipolar disorder is not easy, but in the words of Vincent van Gogh himself, the beginning is perhaps more difficult than anything else, but keep heart. It will turn out all right. This webinar is brought to you by the Symbiosis Center for Emotional Wellbeing. Symbiosis Center of Emotional Wellbeing was established in August 2018 and consists of mental health professionals that are located at various campuses of Symbiosis International University and now SOES as well. They provide counseling services to students, staff, and faculty. I would like to welcome our guest speakers for today. We have with us Ms. Neha Patel. Neha Patel is a psychologist and psychotherapist practicing for the past 26 years. Neha ma'am is the founder of Sharnam Therapy and Healing, a center for psychological, emotional, and spiritual well-being in Mumbai. She is co-founder of the Mind and Arts Institute, set up for teaching the arts-based therapy course. She is also the co-founder of Online Sharnam, an online platform of therapists offering affordable therapy using an integrated approach of Eastern wisdom with arts-based therapy. I would also like to welcome Dr. Rahul Bagley. Dr. Rahul Bagley is a psychiatrist and deputy head at Symbiosis Center of Emotional Wellbeing. He completed his post-graduation in psychiatry from Mumbai and worked under a few senior consultant psychiatrists as well. He is a certified REBT practitioner. He is practicing for the last 7 years and shall be sharing the clinical relevance of the topic based on his experience. I would also like to welcome Ms. Nehal Pimplekhari. Ms. Nehal Pimplekhari is working as the psychological counselor for the lovely Hilltop campus of Symbiosis Center of Emotional Wellbeing. She is a licensed clinical psychologist with an MPhil in clinical psychology. Nehal ma'am has extensive experience in psychological assessments and psychotherapy. Her training and experience in cognitive therapies and various multidisciplinary expressive approaches enables her to effectively diagnose and treat a range of psychological concerns. So, starting with bipolar disorder, I would like Neha ma'am to please let us know if there is, any correlation between art and mood states, and please help the viewers know more about it.
Okay. First of all, thank you for inviting me, and I hope I am able to give information which is going to be useful for everybody, especially since I'm talking about a subject which is not commonly talked about as a therapeutic process, which is using the art forms, the different art forms. And yes, I'm going to change your question a little bit, Simran, and I'm going to call it not just art, but art forms, because the kind of therapy I practice includes a lot of different art forms. So from that perspective, I will be able to answer. Coming to art forms and mood states. Now, if we look at it, we as human beings, we are constantly using art forms, which we are, which impact us, which affect us. Look at any festival of ours. We talk about, Holi, Diwali, even Ganpati, and I mean other festivals where we decorate with flowers, any kind of a celebration, and we are using the art forms at that time in its full glory, because we make rangolis, we make aartis, we have music playing of certain types, and it does impact our mood. It makes us feel a certain level of joy. It makes us feel happy, celebratory. So art forms and moods, this is just one example. If we actually start talking about it, there'll be plenty where how they impact each other. Even if we're feeling a little sad or upset, we tend to listen to certain kind of music that makes us feel a little more, in connect with our emotions. We are able to better express our emotions because of that certain kind of music that we listen to. So there is definitely a huge correlation between art forms and any art form, and also moods. Just to explain this a little further, when we talk about moods, from my understanding and training, any mood comes first from an emotion that we feel. It starts off with an emotion. Emotions actually last for, say, a few minutes sometimes, and just a few hours. It has a physiological expression, and it has a psychological expression of it. And when it is continuing to stay that way for a certain period of time, it becomes a mood, which then which might not have a trigger at that point of time, but it continues to be, person continues to be in that state. So let's take the example of feeling sad or feeling a little low, or feeling a little upset about something, tends to become a mood of feeling low and feeling blue. You may call it blue, how we say, oh, I'm feeling blue, which then turns into a trait. If it continues to stay that way for some time, where a person is generally very pessimistic or tends to be in a very, it tends to be always looking at things negatively, it turns to that eventually. If it continues, that mood continues for a long period of time, which then eventually would turn into becoming a disorder, which is, then to be diagnosed. So I wouldn't go there right now. But it starts off with an emotion which, when extended, so what happens with art forms is that if that emotion is expressed at that point of time, uh, it doesn't. It helps a lot, and it doesn't turn into a upset mood at all times. Where that's where it's really useful. Of course, when we talk about we're talking about this on bipolar day, like the day where we are going to give importance to and bring about awareness about bipolar. So bipolar is absolutely about mood shifts and mood changes. And as we go further on, I would like to explain how art forms will how something like therapy using art forms will be useful for helping in such a situation. As for a regular day-to-day basis, we all are using art forms which impact our mood state. I must also add one more thing over here. Okay, very important, Simran. Do tell me when I need to stop talking, okay? Because I might just continue. So you can tell me.
Definitely.
Yeah, just give me this and I'll go to the next. I'll just stop. Okay, yeah. So one more important thing, sometimes, so I was discussing this with my colleague. I was like, okay, these are the questions, and my colleague who is also an arts-based therapy educator like me, we work together, and it was like, I said, when there is rehearsed art, that time maybe, maybe when this rehearsed, but even when it's rehearsed art, let's say rehearsed art would be then acting. Okay, let's say I'm working in a drama, I'm playing a role in a drama. If my mood is a certain way, my impact of my acting will change. So there is a definite impact of the way you are, your state of being at that point of time. Mood would be more the state of being, where I would like to use it as that. At that point of time, that is going to impact the work we do, the art we use, and vice versa, where the mood will change with the art that you express, and the art will change with the mood that you're feeling. So I think that might be an answer to your question. I hope it's satisfactory and it explains what we are trying to ask.
Yes, ma'am. I think who else but you can put words also into the art and explain it to us in a beautiful way.
Hope it has been
So,
useful.
um, since this is a vast topic, as you are saying, bipolar disorder itself is a vast topic, and we would want to make sure that we cover all the important aspects of this disorder. And one another important thing is that it is not too prevalent in India. So there are a lot of myths and misinformation surrounding this disorder and its symptoms. What are the symptoms? So I'm pretty sure that everyone would want to understand that what this disorder looks like. And while we are learning from our experts, I'm pretty sure that all three of you can help us in debunking some of the myths. So I would like Miss Nehal ma'am to tell us about more about this disorder and the mood states.
All right. So, like you rightly pointed out, that there is a lot of confusion between mood states, wherein bipolar is used in a colloquial manner, where we say that I'm bipolar. So, I would like to pick up from what Neha ma'am has shared, is that mood is more persistent and sustained emotion that colors our perception of the world. So, it is different from emotions because emotions are more specific, they are more intense than mood states. Mood, on the other hand, is less intense and more sustained, and it affects how we see the world. So, if you think of a time wherein you were experiencing positive mood states that were leading towards happiness or satisfaction, and think whether that influenced your day. Did it facilitate creativity? Did it help you arrive at solutions faster? Or did it stimulate interactions between each other? So our certain mood states definitely have an effect on how we are in the world and how we see the world. Similarly, if you look at sad mood states, you would probably want to retract to yourself, be by yourself, limit social interactions. So mood essentially has an effect on how you see the world as well. So all of us have mood fluctuations at some point in our lives. We see these fluctuations almost every day. Some of them are triggered by external environments, the people that we interact with. Sometimes it's triggered by more internal factors. This is normal. Everybody experiences these mood shifts on a day-to-day basis. But what happens with bipolar is much more than that. Bipolar mood disorder is a mental illness that causes change in a person's mood, their energy, and most importantly, their ability to function. So if you're having certain mood swings, it would perhaps not affect our functioning to a degree to which someone with bipolar has difficulty in functioning. You would still be able to do your everyday tasks like going to school, meeting friends, pursuing certain hobbies, despite of what's happening on the inside. So bipolar disorder, on the other hand, it can cause both social and occupational dysfunction. So mood swings, on one hand, typically last for hours rather than days, whereas in bipolar, you would see that, okay, the time frame and the intensity, severity of these shifts are much bigger, much more. So these changes, they are accompanied by extreme degree of behavioral change, difficulty with daily routines, difficulties with social interactions that people with bipolar disorder demonstrate. So the key difference are timing and severity, right? Now the confusion arises because of the term bipolar, two poles, which is why it is used to describe anything that is conflicting these days. I'm feeling sad and feeling happy really quickly, fluctuating between those two. Or sometimes even the weather is described as being bipolar when it's raining at one time and it's sunny the other. But when we are talking about bipolar disorder, we must remember to be very mindful of the term that we're using, because it is a deliberating illness, and it is affects the person and the people around them to a large degree. So the key differentiators are the severity, intensity, and the amount of time that a person experiences these symptoms, so to say.
So, I think all of us would agree on this, Nehal ma'am, because these days, a lot of students or, people just come, they just Google and then they're like, okay, I think I have this. I think I have that. Okay, I think I'm bipolar. And it is very important for us to be very sensitive about the terms that we use with respect to mental health and how it can affect others. And I was just wondering about, because you told about the two terms and how a lot of individuals just use it. What exactly, are the symptoms of bipolar mood disorder? And if there are any types of this disorder, I would like Dr. Rahul to, please let us know more about this.
Yes, thank you, Simran. So as Neha ma'am correctly said it, that emotion would last for a few minutes or may hours, and if that becomes a pervasive state few days, then it would turn out into a subjective mood state. And adding upon to the Nehal's description about bipolar mood and the myths related, I would also like to tell our viewers or audience that labeling anyone is not a good way with respect to these disorders. Many times, if someone is getting angry, irritated, the friends of circles in you might be saying some words related to any disorder related words. So that is not a good way. Disorder is something, a severe form of illness. And if even anyone is having that illness, that is not a total their responsibility. It is happening with them. It is not they are choosing. So be gentle, be compassionate with the individuals who are having any mental health issues. And this way we will definitely learn to get out of this stigma and make the most of abilities of the individual who are going through any mental health issues. So coming back to your point, Simran, it is a huge task, I would say, that what are the types of disorder and what are the symptoms. I'll just make it in a simple way. So to give in a brief, the lifetime prevalence of bipolar mood disorder is around 2.5 to 5% based on the type. The type 1 is usually 2.5%. So if 100 individuals we take at a random, then 2 or 3 individuals in that 100 individuals would be likely to have bipolar disorder in their lifetime. And for bipolar type 2, the incidence is quite more than 2.5, it may reach up to 5.5%. And there are some distinct episodes of mood which the criteria is described. So the foremost and important episode we are going to discuss is about manic episode. So manic episode is usually at least 7 days. It is a criteria that at least 7 days pervasively, intensely, if an individual is experiencing some symptoms of manic spell, then maybe we can make it sure that it is a manic episode. So there are certain symptoms about this manic episode that I would like to highlight here only before we move ahead with the types and all. So in mania, what happens? The individual is very abnormally and persistently elevated in his mood, or sometimes he is just feeling so irritable that is not in a proportion to his baseline personality. Everybody knows how a person is, but all of a sudden, I mean, someone is likely to be too much happy for without any reason or for minor reasons, or too much irritable, aggressive sometimes as well. So then it is something we should be careful about, whether it is something a change in mood. And the individuals facing this manic episode also develop this grandiosity. They have some big ideas, big thoughts, which are not in a realistic sense. Sometimes they will just assume that they are some rich person, they are big celebrity, or they have contact with some influential people, although they might just have clicked somewhere around, and they will just try to contact them or just try to portray them that they are having this much amount of money or property, and they will keep on donating also this money in the misbelief or delusion, we can say, where they assume that they are someone big. They usually people feel like there is no need of sleep in mania, because so much energy enters into their system because of the brain chemicals that got deranged. So they feel like there is no need for sleep at all. In comparison to other symptoms, usually a mental health professional comes across that they are not able to sleep. In mania, they feel like, I don't want to sleep. I want to keep on being productive enough. I want to do n number of things in my life. I have this much goals. So there is excess goal directed activities that I want to finish this task, then I have this big task, I have to finish this way. So doing it on a regular routine way, considering the temperament of individual, is fine. But if it is just crossing some other way, then we need to be careful whether it is a mood fluctuation or something as a towards pointing a disorder. The individuals keep on talking excessively. They keep on talking so much and persistently, with jumping from one topic to another topic, that we call flight of ideas. They just talk one topic, and then from this topic they derive another topic, and that doesn't make a clear sense what they are exactly going to talk, and they just keep on jumping the topic. So this kind of a speech we can get from that individuals. There is a high distractibility because of the racing thoughts, continuously thoughts they are coming into their mind. They get easily distracted with the stimuli around, and it is difficult for them to focus on some particular their socio-occupational functions. They may keep on buying something that are not needed. We call it a buying spree syndrome. So they keep on buying the objects or something or their belongings in a huge amount with a large or disproportionate quantity or the price they usually buy. There might be some risk-taking tendencies also, because in many episode there is a loss of judgment, and this impaired judgment makes that individual to disturb their decision making ability. So there could be some indiscriminate sexual activities. There could be some financial risk taking tendencies, like nowadays we see some people get into share market or something, and then they keep on buying in a way or the shares or whatever, and they get into some risk taking tendency, and they just lose the reality with lose the contact with reality. So in a way, these 7 days are totally like hell for that individual and the family members around, because they haven't seen this kind of behavior in that individual. If we come across any of these symptoms, not all symptoms need to be there, at least 3 to 4 symptoms are sufficient for diagnosis of bipolar mood disorder. So if we come across any of these symptoms and we feel like this is not in a way the behavior the person used to have, then we need to be careful to take help from mental health professional. So this was all about manic episode. Now we come back to the depression. So depression is something which lasts for just two weeks at least, and pervasive state. It is a continuous state. It doesn't get like 3 days you are feeling low, and then again for 5-10 days you start feeling better. So at least most of the day you are feeling low, and you don't feel like to do anything. Your interest or pleasurable activities just shut off by your own. Even if you don't try, if you try, you are not able to do that. There could be some significant weight loss or gain also. They might not be able to sleep, or they will be feeling so lethargic or tired they won't be able to do any activities and just keep lying on the bed. At the end, they might start feeling worthless about the life situations they are going on. They might feel helpless that how they are going to come back into their routine, and they may lose hope with the reality also, that maybe they won't get it better through this. So this depression episode usually lasts for 2 weeks, at least 2 weeks, and then only it becomes a diagnosed depression. Not just that I'm just feeling depressed, like people or students say sometimes I'm just feeling depressed. So feeling depressed is or like feeling sad, and depression is something a disorder which should be at least for 2 weeks. So in between this manic phase and depression phase, there is one more phase to be added to it. So this phase is called hypomanic episode. So hypomanic is something like below the manic episode. It is not that severe like manic episode, but it is still carrying some abnormal behavioral from that individual. The symptoms more or less are the same as mania, but they are light in intensity. Probably the elevation of mood may be not that grandiose. There could be some decreased need of sleep, but they are going to maintain their life functioning. There could be some excess goal directed activities, which possibly based on some realistic life expectations. And there is a less likely chance that they would have any socio-occupational dysfunction. They are likely to maintain their functioning. Probably they are functioning at above their level of abilities, and sometimes that's the reason some patients do feel that those were the days when I used to feel so much good. So if we ask them that do you remember if any of the days or phase in your life when you were feeling very good and that was the best time in your life, if we ask this question to anyone who is going through depression, more likely they are going to say about this hypomanic spell, if at all they have experienced any. Or if any normal mood is there, then they are going to say just it was a normal mood and it was like I used to be before. It wasn't much better than I could perform. So this hypomanic episode usually lasts for 3 to 4 days, and it just repeats its own sometimes, or it may get into a prolonged state. So looking at the distribution among different genders, so depression is usually more common in women, as the data suggests. But for mania, it is more common in men. So many episodes are more likely to happen in the men, and especially in the young adults or the late adolescents, like some 15, 18 years old individuals to 25, 30 years, which is the time where usually we get the first episode of mood. It could be mania, it could be depression or hypomania. In women, there are sometimes a term called as rapid cycling because their mood keep on fluctuating very frequently. These episodes of distinct time duration, they occur very high in frequency in a year. Maybe in a year they have 4 mood episodes. They could be like 2 depression episodes of 2 weeks each. Then again one manic episode, one hypomanic episode, and in this permutation combination. So that determines how their treatment guidelines are going to change. And so looking at the uh, types of bipolar mood disorder, so based on these types, that manic episode, depressive episode, and hypomanic episode, there are 2 types of bipolar mood disorder on a broad perspective, which is a bipolar 1 and bipolar 2. So bipolar 1, the hallmark of this type is the manic episode. If an individual had manic episode in her or his lifetime anytime, and they may or may not have a depression episode, but manic episode was for surely documented for these 7 days, then this disorder becomes the bipolar type 1. And not necessarily there has to be a depression episode. Just a manic episode is sufficient disorder. There are mixed episodes of depression and hypomania. So maybe sometimes they will be experiencing some depressive episode. They may start their illness with some depression, and then sometimes they will get a hypomanic episode of 4 days, and then again after a while they will get some depression. So usually if someone is diagnosed to have bipolar mood disorder, there is a chance that they will get at least 2 to 4 episodes in their lifetime, because this is something happening with their brain which is not totally in their control. Definitely we can work on some therapeutic measures, some art-based therapies to keep their mood in a regulated sense, but sometimes neurochemicals play their role and we have to obey with them, and we have to accept what the statistics say. So at least 2 to 4 episodes are likely to be there in their lifetime if anyone has this first mood episode between 20 to 30 years of age. And I would like to share a brief case scenario that how an individual with bipolar mood disorder had it. It is just a kind of a case. I'm not revealing any details related to it. It is a anonymous case, I'm going to say. So there was a student of 20 years age. So he was very dedicated in his career, and somehow the first episode he had a depression that he couldn't excel in his career. So on the first occasion he came to any mental health professional, there noticeable signs of depression. So he was not able to maintain his day-to-day life. His sleep appetites were disturbed and all other depressive symptoms. He fulfilled the criteria for 2 weeks with those depressive symptoms. And then maybe he developed well with the treatment, the therapy, and the medication he was advised. And then after maybe few years or maybe few months also, he started having these grandiose thoughts or started feeling like I can do more than what I can actually do. And this turned out into hypomanic to manic episode. Because sometimes in a depression, if an individual is not able to deal with life stresses, there could be career related, finance related, or family related, then their subconscious mind, their mind just starts uh, thinking in a way to just hide this lacune in their life, and they just make this reality in a sense of bipolar hallmark, that is mania or hypomania. So this way they get some other episode later on. So how an individual, because depression is quite common, maybe we can say 4 to 7% of individuals are going to experience depression in their lifetime if we check the lifetime prevalence. Then are there any commonalities that someone who is having depression is also likely to face bipolar also? So yes, there are certain factors which can predispose an individual to bipolar disorder, which a clinician and mental health professional also need to be careful, and the individual can also give these details to their mental health professional so that their adequate treatment plan would be formulated to avoid any manic or hypomanic episode. Some of the predisposing factors are the hyperthymic temperament. Some individuals have a very talkative, very friendly, very extrovert nature. So if they sometimes, nobody would expect that individual will get into depression. But if at all, because of some life stressors or because of some brain chemicals derangement, that individual gets into a phase of depression or episode of depression, then it becomes very unnatural for the family members and friends to identify this, and they just notice it and they say you were not like this before. So that contrast, if you see, and if you notice that individual initially was very well to do with his all the functioning, and then this depression has set in, we need to be just cautious enough that whether we get any symptoms of hypomania or mania. Sometimes people start using substances like alcohol, marijuana, some stimulants like LSD or this methadone, which is quite prevalent in metro cities. And using that substances makes those individuals prone to develop bipolar disorder, because of these substances directly attack the brain centers which are involved in neurochemical synthesis and distribution, and they are likely to get into manic or hypomanic episode if they keep on abusing substances. So I request all of the students to avoid any substance use, whether you have any mood disorder or not. Even using some substances like marijuana and similars is documented to have a mood episode, even if you are not about to get any mood episode. Just because using substances, there is a high chance that an individual will get into mood episode. It could be depression or mania, hypomania. Some individuals who have some emotional personality disorder traits or disorder itself, which is also called as borderline personality, so they are likely to face this bipolar type 2 diagnosis based on the criteria if they have, because they are more likely to experience this upheaval of mood because of their personality traits also, and because of this disorder which is adding some other flavor into that prognosis. So they need to be careful, and they need to convey it to their mental health professional. Maybe mental health professional can do a personality assessment also. If they are suspecting that it is not just depression, it can turn out into a hypomania or mania. Some medical condition like hyperthyroidism is likely to give rise to manic episode, and hypothyroidism in contrast will lead to a depression state. Some family history that we are going to share here now, which also includes the high chance if some of the close family members, if their twin or their parents have any mood disorder history or even some other disease, mental health disease history like schizophrenia, they are likely to have this chance of getting bipolar disorder. So they just need to be cautious. It is nothing to be worried about, because anyhow, no individual is going to be a disease free, whether it is a physical health or mental health. So we just need to be cautious what bracket we are into high risk and what ways we can try to reduce the chances we have, or how we can identify them early and keep on working to maintain our mood states. Over to you, Simran. Any further details required, please let me know. Thank you.
So, sir, I think you have explained it very beautifully, that what are the symptoms and real life examples that people do face, and what actually goes on in the family, and what are the types of disorder. And one major important thing that you brought up was that about an individual who's actually very happy in real life, and when he or she or they get depression, and no one can actually accept it, that okay, how can depression happen to them. That is such an important thing for all of our viewers to know. So since we talk about the things that can happen and do happen in real life, and especially with the example that you give, the anonymous example that you shared with us, one another question that I was wondering was that what are the things that can make an individual prone to bipolar disorder? Because now that we know what are the types, now that we know how does the symptoms look like, we also know, like, this is something that is happening to an individual. Not no one would want to go through this. This is something that
Yes, got it,
has.
Simran. Yes,
Yeah.
yes. So to give in a brief, the biological factors are something that give rise to mood episode, the first mood episode, and they just keep on worsening the mood episodes. And psychosocial factors are there. They will be covered by our counselor Nehal. So I just give in a brief about biological factors. As I said, the family history. If someone is having close relative with mood disorder, could be depression, mania, or could be schizophrenia also. So they have been sharing some common genetic material on some chromosomes of 18, 20, 21. A gene called BCR gene, they are having some predisposition to make an individual prone for bipolar mood disorder. So if one of the parent is having mood disorder, there is significantly high chance that the children of them are going to experience some or other mood episode. So these are the biological predispositions. And one thing I would like to say, that first episode we need to catch it as early as possible. Because the first episode there starts the neuronal degeneration and extreme damage occurs in the brain, which is not just visible through any scan or any imaging. It is just being visible through the observation of by their family members and the clinician, how who can detect those signs. So please don't delay when you experience any of these symptoms for this diagnostic criteria duration. So seek help as early as possible. I have been dealing with few patients who come to me just 3-4 days and they're experiencing these symptoms, and they are doing really well once the treatment was started, because we just abrupted that manic episode that time and the neuronal damage was reduced and they were much stable state. Their mood episodes were less intense, they were less frequent, and they could cope up well in their socio-occupational functioning. So delaying for the treatment, any form of treatment, medication or therapy, will just be detrimental to their overall health. So please seek help in time. And I think for psychosocial attributes, Neil is a good personnel who can guide us about that.
Could you please let us know about the psychosocial attributes?
Yes, certainly. So, all right. So our genetic makeup and biological components are certainly really crucial components of the illness. So these factors are something that is known as the diathesis, which is the vulnerability towards developing a particular illness. So diathesis is like a loaded ammo. It forms the vulnerability of development of this disorder, but there are certain psychosocial factors as well which have been identified, which influence whether the trigger is pulled and the disorder is manifested. So these may be an event or a series of events that disrupts a person's psychological equilibrium and may act like catalysts to development of a disorder. So when we talk about diathesis and stress, this model suggests that when an individual has vulnerability towards illness, these stressors in it can activate a particular illness. And it is usually more complex than that, since both diatheses and stressors, they can interact with each other. So I would talk about some of the psychosocial factors that play a role in the development of bipolar disorder, or even the maintenance of these episodes. So stressful life events, we know that they have been known to precede, maintain, as well as increase the time of recovery in depressive as well as in manic episodes. So these stressful life events are subjective in nature, meaning that some people might find certain stressors manageable while others may not. So periods of stressful events, they can range from disappointments to failures, perhaps as a death of a loved one, loss of a relationship, loss of a job, financial difficulties, or something bigger that's like a natural calamity. So it is important to know that what may be stressful to one person may not be as stressful to others. So even things like disappointments or rejections might come across as very stressful events for certain individuals. So it is extremely subjective. So these stressful life events certainly have an effect on whether a disorder is precipitated, an episode is precipitated, or whether it is maintaining a particular episode. Contributes in both. The other important factor is social support. This is important for any kind of illness, not just bipolar disorder per se. So even if you think of a time when you were ill, you needed people around you to support you, to take care of your tasks, to accompany you to go to the doctor's appointments, or just simply ask how you are doing on a day-to-day basis. So that makes a huge difference, right? So when this social support is lacking, what do we do in such situations? So during times of recovery, during times of remission, a person with mental illness will definitely require adequate social support. And an absence of such a support may have very detrimental effects on the person. And studies have been shown that an absence of social support also cause frequent recurrences or relapses in manic or depressive episodes. So that's another very important factor. In terms of personality, a trait that is known as neuroticism has been identified. This is also a heritable trait. And neuroticism is a disposition to experience certain negative emotional states more frequently than others. Now, these negative emotional states can be anger, anxiety, self-consciousness, irritability, emotional instability. So this trait, this has been observed to be evident in those with mood disorders, and it is also associated with increased symptom severity in bipolar mood disorders as well. So these are some of the psychosocial factors that I spoke about. Another important factor is our lifestyle. Why? Because it has a role in our circadian rhythms. So circadian rhythms is approximately a 24-hour cycle in the physiological processes of a human being. So these rhythms are the reason why we feel sleepy at a particular time, or we feel hungry at a particular time, and so on and so forth. So these rhythms are endogenously generated, which means that they're generated from the inside, but there are external factors that can influence these rhythms, external factors like temperature or sunlight. But now if we look at the current context in the modern society, we are no longer governed by the availability of natural sunlight, as there are artificial sources of light that are readily available 24 hours a day. And by extension, social factors like the timings of meals, our work schedules, the schedules of other family members, television programs, they all have a substantial influence on when we go to sleep, what time do we eat, how the rhythm of activity, productivity changes. Yeah, so even at 11 o'clock, wherein we are supposed to be sleeping, we would find ourselves on Netflix or working, and that's going to disrupt our rhythm in a way. These disruptions, so all of us experience these disruptions at some point in our lives, right? Even if we take jet lag, for example, many of us have experienced the fatigue that's associated with the jet lags. But we are able to adjust ourselves into different time zones pretty quickly. In a couple of days or so, we are able to do that. and the distress that's accompanied with it, that dissipates quite rapidly afterwards. But with individuals who are susceptible to certain mood disorders, this sort of adjustment becomes much more challenging. In essence, they feel themselves trapped in disturbed circadian systems. So they're not able to reset their circadian rhythms as quickly as other individuals can. And as a result of this desynchronization, individuals might experience or a trigger towards a depressive or a manic episode. So we've spoken about, and also Dr. Rahul also mentioned substance use, which is again a very important contributing factor. So we spoke about the diathesis and the possible psychosocial stressors, and an additional very important component which is often missed when we talk about this is something that's known as protective factors. So protective factors are conditions or individual attributes that guard or protect against developing these illnesses. So say for instance, even if I do have this diathesis and I've had a relatively stress-free life with enough protective factors, the chances of me developing an illness reduces. So these protective factors, it's very important that we learn to identify what they are and deploy them to our benefit. So these factors need to be taken into account, and they can be certain skills that we develop over time, the strengths, our resources that we have, internal as well as external, in the form of social support, resilience, coping strategies. All of these act as protective factors, and that is also something that needs to be taken into consideration when we are having this discussion. So I hope I was able to answer your question in terms of the psychosocial causal factors.
Yes, yes, Neha, you were, you really were. When we talk about protective factors, and you really did tell us about the psychosocial factors. When we talk about protective factors, does medication also come in one, or if it is or if does not, how does medication help in treating bipolar disorder? And Dr. Rahul, would you like to tell us more about it?
Yes, yes, sure. So as we discussed, there is some genetic predisposition that may make an individual prone for bipolar mood disorder. So we have to work on the biological factors, and especially during the first episode, acute episode of depression, or with suicidal ideation during depression, or in the manic state where totally the judgment has been impaired and individual is totally into some elated mood or aggression, that time medication are the mainstay of treatment for acute management to just settle down their neuronal centers, harmonize their neurochemicals. So that will help them to calm down at the first episode. And the medication, what the guidelines say, usually medications are started with the diagnosis criteria being fulfilled, and then they might be needed based on the episode for adequate duration. The duration may vary for each disorder. For example, for the physical illnesses, usually we are not used to take medication beyond 5-7 days. Even if we got any infection, we are just like 5 days antibiotic. That too, some people miss 1 or 2 days, to be frank. So for maintaining adherence in bipolar disorder is a tough task. So individuals need to understand that this disorder is something happening to them because of the brain chemicals, and it would be needed to be balanced with some medication along with therapeutic measures, which are our best therapist Neha ma'am and our counselor Nehal is going to guide us. But the medication has some role in especially initial few months or maybe a year also, when some minimum medication would be required to keep the dosage adequate enough and to prevent the relapse of those mood symptoms. Once they are doing well, once they have started settling well in their life, because if you see 20 to 30, these are the age spans where people are doing something new. They may get into new career, they may start some new business, they may start some new job, they may get into relationship or marriage, and these things totally impact all the view of this bipolar disorder. So after maybe 30-35 years, some stability is there in their life. probably they are not likely to need any of the medication longer, but at least in initial few phases, medication have their role. And if some patients who are being diagnosed with rapid cycling, that their mood keep on changing very frequently, there are more than 4 episodes in a year. For those individuals, some mood stabilizers need to be started. So mood stabilizers are different class of drugs, and every medicine has some strong effect on some particular symptoms, and maybe possibly some untoward effects also. I understand that individuals are pretty conscious about the side effects of the medicine, but looking at the disorder severity, we have to weigh somewhere the risk benefit ratio. That if we are not taking the medication, our whole life is going to be spoiled, or few of your years are going to be wasted in the disorder, and that is not going to be a fulfilling life. If some side effects are there, we can definitely report those to the clinician so we can manage some of the minor side effects. And some severe side effects, if any are there, they can be monitored with some blood levels. And if any severity is there, we can change. There are wide range of medication available for bipolar mood disorder now. It is not the time of 1980s or 90s when there were just 2-3 medication for any disorder. So there are definitely multiple new drugs coming on, new medication are there. So I just want to give hope to individuals who are having bipolar disorder in case they have experienced any untoward side effect, and then they just deter from treatment and keep on experiencing these depressive episodes or manic episodes been untreated. So please seek help from your nearby institute or the professionals, because one experience may not determine how your mood state had been. Probably you can just discuss these issues with your clinician and get help with some therapies also, because therapies will help to reduce the medication load. As Nehal ma'am initially pointed out, the emotions can be regulated through art-based forms, and that will definitely help. Whatever literature maybe she can guide us, and I also been reading through that, so they definitely help in maintaining some emotional states. And the interpersonal things are quite important. I would request our counselor Nehal to focus onto that, how interpersonal relationship can be managed well to avoid the triggers of bipolar mood episodes, or how we can prevent the multiple episodes in an individual who is having bipolar disorder. Yes, Nehal, please say something about it.
All right, so I'll talk about the management in terms of psychotherapy. Like you pointed out, interpersonal psychotherapy is one of the techniques that's being used, which emphasizes on the person's learning to recognize their interpersonal patterns and act more effectively in relationships. So interpersonal psychotherapy, essentially, it incorporates a variety of interventions in understanding and modifying these interpersonal behaviors and responses that contribute to depression. So these interventions can range from non-directive questioning and interpreting certain relationship patterns in as well as outside of the therapeutic setting, to more directive techniques like skills training or social skills training, psychoeducation, and practicing what they've learned through role plays. Another kind of therapy that I'd like to talk about is something that's called interpersonal social rhythms therapy, which is an upcoming therapy in the treatment of bipolar disorder. So we understood how disruptions in circadian rhythms can trigger a particular episode. So on the basis of that, interpersonal social rhythms therapy focuses on stabilizing the circadian rhythm disruptions. So initially, the degree to which the timing of a person's routine varies through any given week, that is charted out. In order to do that, the person is asked to observe and note when he or she goes to bed, when they eat, when is it that they step out to go to work, the kind of social contacts they make, when is it that they do so. And after this is noted, the clinician helps the patient regularize these timings of such routines. So ideally, it shouldn't vary more than an hour. So once a reasonably regular routine is established, we review with the patient the possible triggers to the rhythm disruption that might surface in the near future, such as on the weekends or when there are guests, or if you're going out on a vacation, that is likely to change your routine. And we try to work on strategies for maintaining the greatest amount of regularity despite the presence of these possible disruptions. So here we attempt not only to increase the stability of these rhythms, but we also try to increase the person's awareness of how easily these rhythms can be disrupted and how is it that we can manage it in face of certain potential disruptions. So that is the crux of interpersonal social rhythms therapy. Another therapeutic technique very widely used and is cognitive behavior therapy. A lot of research done on CBT. And the core objective of CBT here is to identify and change certain maladaptive thoughts, beliefs, and behaviors that contribute to the manifestation and escalation of these symptoms. So CBT is based on a premise that your thoughts, your feelings, and behaviors, they're all interconnected. And the shifts in mood and shifts in thinking processes during a depressive or manic episode, they would influence your behavior. And all of this would lead to a vicious cycle that contributes to illness burden or illness severity. So CBT is most effectively used in helping individuals recover from bipolar depression rather than manic episodes. So it involves psychoeducation about the illness, the common patterns that an individual might experience, the biological, psychological, social factors that influence, and the rationale for treatment and the importance of treatment adherence. So once psychoeducation is done, they have enough information, we move on to understanding and monitoring moods via something that's called mood journaling. So this gives us an understanding of whether there are certain triggers that have caused these disruptive mood states. It helps individuals rate the severity of their mood states from a scale of 0 to 10 so that they're able to reflect on these things. And because the rationale of CBT is that thoughts, behaviors, and emotions influence each other, we move on to understanding certain negative cognitions or certain negative automatic thoughts that accompany these depressive symptoms and learning how to restructure those thoughts into a more adaptive kind of a thought. So if you are able to restructure these thoughts, it would in turn have an effect on the emotions that we are experiencing and the behavior as well. So CBT is also used to deal with the feelings of anger and guilt that accompany after a manic episode is over. So once an individual reflects on their behavior during these episodes of hypomania or mania, there might be emotions arising because of it, emotions of guilt or anger. So CBT helps with those emotions as well. So it helps an individual equipped with certain coping mechanisms and problem solving strategies to help them manage their symptoms in a more adaptive way. Additionally, there is role of family therapy and certain group interventions that have also been effective. Family therapy is used to help family members understand the nature of the illness. They are taught to recognize certain warning signs of either a manic or depressive episode so that they're able to catch on those signs early and have early intervention if there is a possibility of relapse. So these family members, they play an integral role in helping individuals identify the early signs of relapse or helping a person adhere to medicines, which again contribute to the maintenance of or being in remission. So it also in turn involves getting adequate support for that individual who is suffering from that illness, right? So that's one component. The other is group therapy and support groups. So these experiences can be really isolating. Although family and friends might be able to care for that individual, they might not fully understand what's going on with them. So this is the reason to think about perhaps joining a support group with people who have similar experiences. So this facilitates dialogue between individuals, helps them troubleshoot certain issues and solve certain common difficulties that they might experience. So in a nutshell, these are the psychological interventions that can be used for treatment.
Okay, so Thank you, Nehal ma'am. I think for the individual, mostly it is CBT and mood journaling, as you said, and support. It is support, group therapy and family therapy for the family to understand and to support the individual. Now, since we are still talking about protective factors, I'm pretty sure that, I would like Neha ma'am to also tell us about, how does art form based therapy or art form as you told, is, can be helpful or a protective factor for individuals having bipolar disorder. Ma'am, I would please request you to tell us more about it.
Yes, surely. I've been listening to everybody, and there's a treasure of information that has come in, and I was just observing the interconnections that are there with and the complementary aspects of arts-based therapy. Before we go any further, I would like to explain one important thing. I would like to tell everybody who's listening that arts-based therapy is a therapeutic process by itself. Like we have CBT or any of the other, EMDR and other, therapies. Arts-based therapy by itself is is a method by itself. So very quickly, I'm going to tell you all about that because it's different than the other expressive arts therapies, it includes all of them, but it is a method to this one. Arts-based therapy is an integration of drama and theater, visual arts. So drama and theater would include storytelling, it would include drama games, it would include role playing and embodiment, and a whole lot of aspects, using puppets. So a whole lot of aspects where drama and theater are concerned. Then there is visual arts or visual aesthetics, as we call it, where in visual aesthetics, it's about not just about using art, painting and drawing. That is obviously an important aspect, but it is also about the aesthetics. So, for example, when a person is putting things together creatively in a room, that is also called visual aesthetics, and the emotion it arises, it brings, or the way it makes you feel. So visual aesthetics would also mean us wearing the earrings and the bindi, women or men wearing a tie, combing their hair in a certain way. All of that becomes inclusive, and it might sound, but how we take care of ourselves is also an important aspect of how our mental health will be, and the awareness or mindfulness of regarding that. So visual arts and obviously it includes all the arts and crafts methods and a lot of different aspects of that. Then there is music, where we talk about music. It is where it's rhythm, voice, using both of them for the purpose of therapy. And the basis of arts-based therapy lies in study of the mind from the Eastern or Indian perspective, along with the neuropsychological, scientific understanding, which comes from all the research that is happening on the in the Western world. So it's a marriage of both. The reason for getting into this at length is to understand that it includes a whole lot of different aspects. As Nehal was speaking about everything about the different therapies, and I was just realizing that, of course, I also am well versed with CBT, and I use CBT a lot. Use mindfulness a lot. All of this is integrated into arts-based therapy. When I say CBT, so the basis of arts-based therapy, the wisdom, is about understanding that our emotions can create the difficulties in our life, the afflictive emotions, and how to work, and the thoughts that we generate as a result. So that is the basis of arts-based therapy, the wisdom behind it. And the method we use is using the art form. Now, specifically, how do we use it for the purpose of, where, bipolar disorder is concerned? First of all, I don't like calling anything a disorder much, but we're talking about the state that has been reached where, we have gone beyond the regular functioning, which is, if you look at it, we all are on a continuum. We all have all this, all the signs of a milder version of a bipolar disorder every now and then. But when we have reached a certain level of, and it's affecting our functioning, that's when of course doctors and we all as clinicians, we can come to a certain diagnosis that this is what the person is going through. These are the characteristics that the person is showing. These are the symptoms that the person is showing, and we need to work on those. Where arts-based therapy is concerned, we work more on the patterns and the patterns and the characteristics that the person is showing. So there is no particular kind of therapy that will be done only for people with undergoing depression or only for those with bipolar. It is about the characteristics that, the patterns that are repeatedly showing up, which is what needs to be worked on. I found this very interesting. Like you said, it's a relatively new therapy, which I did not know about. IPSRT that Nehal was talking about. And Nehal and everybody, it's very interesting because one of the core aspects in arts-based therapy and using art forms is awareness and mindfulness. Being aware, and so obviously when someone is going through a bipolar episode or is suffering from a disorder as such, their awareness is minimized. So through art forms, bringing about that awareness, to using the art forms, because they are in the moment, you're doing something there, and then you can reflect upon it. So those, they become very, very useful for developing the mindfulness. And we actually make people practice it through the art, through arts-based therapy. I mean, the client, the person who has come to us for therapy. There is another important aspect. We've been talking about Vincent Van Gogh, and he had said, I'm going to quote this. Let me just pull it up, the quote. We all know that he would project his turbulent emotional experience onto the canvas. And he once said, what lives in art and is eternally living is first of all the painter and then the painting. So it's a complete expression of the self, whatever that person is going through at that point of time, through the art. And to be able to express in the first place, and to be able to sit there and, when you're in that frenzied mode, I might call it that, in that state, sometimes, we know how we've all heard about how it can be. And or even when the person is feeling this sense of vacuum, when the grief is, when the depression is so deep, there's a sense of vacuum. At that point of time, to be able to express through any of the art forms how you're feeling in that moment is where arts-based therapy can help tremendously, where mood regulation is also concerned, because it brings awareness. So what happens is, there's so many methods. There is a different method used for each person, depending on what. There's a whole, like I said, the whole therapy is very structured, within which there's a lot of flow. So what happens is then that with each individual, we come up with individualized goals, and also there's group work happening, because very often it's a group of people undergoing the similar issues who are doing the session. So group therapy is also included within within arts-based therapy, and then everybody is, depending on their group goals and individual goals, the sessions are planned. So where mood regulation is concerned, first of all, awareness of what's happening to you in this moment, through the different art forms, through reflecting, through expressing, through developing different skills for the purpose of doing that over a period of time. And the best part is, along with other therapies, along with the medication, there is no issue in any of that, no, now you can only do this and you can't do anything else. It complements everything else. And to be able to ground yourself through meditative techniques. Now, meditation is used very carefully when, because it can only take the person deeper. And so it's more of mindfulness work, being aware of what's happening to me in this moment, being able to reflect that, and also understanding that that's not your permanent state, which is an important aspect of arts-based therapy, that it is how you are in this moment now. It is something that can change. It can shift. These are the different kinds of understanding. So I would call it the antidotes to the difficulties, to the afflictions, or we call it afflictions, to the afflictive behavior or moods that we help with. The journey from one to the other is what we work on. So let me just ask you all. So let's say if I generally ask this at your worst, okay? And if you all don't mind, because it would be nice to have you participate in this.
Yeah.
If I'm asking you right now that in a symbolic form, tell me, how would you describe yourself as a metaphor at your worst? I'll give you an example. At my worst, I feel like a wilted flower. When I'm not in the bed, and I feel like a wilted flower. And if I was drawing it, I would have drawn a wilted flower. If I was acting it, I would be like, I would do this, like, this is me as a wilted flower. This is me at my worst. Okay. So could all of you also give me one example of this for yourself?
Okay, so if if I have to tell that how I would draw or tell myself at my worst, it would actually be you know um, probably a dandelion flower that just flows in the wind or the air. It's just going like one by one.
Just
It's just going.
is just going, just
It's like,
breaking away
yeah,
one by one. Yeah. Okay.
yes. So it's like just leaving one by one.
One by
That's
one. Very nice. So just stay with that. Okay. Dr. Rahul, would you be able to share just in one word if you want to, how would you feel
Yeah.
at your worst?
It would be a really interactive thing that you have suggested, Neha, ma'am. So it will really help us to know more about this way. So I would like to consider myself not as a flower, maybe as a fruit, something,
Okay.
maybe an apple that can
Okay.
be used for everyone to eat and nourish their.
That's how you feel when you're at your worst. Is that what you're saying? That it's
At
anybody
worst, okay, you were
at
saying
your
at
worst,
worst.
at your worst, at your worst. Yeah.
Okay, I thought I just had to think again about this.
Okay,
Way.
no problem. Anything that quickly comes to your mind. I just wanted to give you all an
Okay,
example of
maybe
how this.
Nehal can share till that time.
Hell, can you think of something how at your worst? Yeah.
Like a pit.
Like a pit. Lovely. Okay. Now, this is one aspect, and we would tell them draw it out. At your best, at my best, I turn into this butterfly. I'm just this butterfly, this butterfly flying around. That's me at my best, flitting around, just looking lovely and even feeling totally at ease, flying around and with on all my beauty. That's me at my best. Simran, at your best.
actually think of a rainbow, me,
Rainbow,
with all the
lovely,
colors and being
very
colorful.
nice, lovely. Nehal,
I think like a blooming tree, grounded
lovely,
but reaching
lovely.
upwards.
Yes, lovely. So what we then do is we say, okay, our journey is going to be from this to the other. And we know that we won't be in this state forever. This is at my worst, this is at my best. Okay. And I will sometimes be at the butterfly, I will sometimes be the wilted flower. But I know that there's a path I can go to. And then we actually ask the person, okay, let's draw this path. What are the hurdles that you're facing on this path to move from here to there? So that they know that there's another space to be in. Because, I mean, in a manic episode, they'll feel like there are 1,000 butterflies also. That is also possible. But it's possible to come, then the path will be different to come to a state of being more integrated. So there's this is just one tiny little technique out of the thousands, I don't know, unlimited number of different, ideas that we use and which come on the spot very often. They are very, they can, based on what the person is letting us know about what they are feeling. For grounding the person, for something like regulation of mood also, see, these things happen at a very, these things happen over a period of time. Any art form will show its effect over a period of time, any usage of art form. One of the things we also, which is my teacher, who's also a part of Symbiosis, and I think he teaches drama over there, if I'm not mistaken. Anand Chabukswar, he's a drama therapy teacher who I've trained with. And he says that, please remember, when there is something you need to do, there's do the drama, there's a stage for it. When you're off the stage, sit back and just be. Don't participate in the drama. So we have all of these different ideas that we work through, which we then put into action through the art forms to express this. That we give them the space to be able to express themselves. The stage is there, and then slowly the person knows that I don't need to always be in that. I know that I can separate this from this whole the way I'm feeling. Now this is all a longer process. It becomes quite difficult to explain it all within a short time over here, because each individual and each individual's journey becomes very different when they're going through something like arts-based therapy. To just also very simply put, what happens is they're able to step out of themselves. See, when we are constantly in a right now also, when I had to do this, I was like, I mean, I've talked about arts-based therapy, I don't know how many times by now. Every day we're talking about it in different manners. Yesterday I did a seminar online for someone, and so there is but when it's supposed to be done in a certain way, then I was nervous. I was like, okay, how do I, what do I, should I say this? Should I not say this? And I was discussing it with my colleague. And in the process, we both just kind of very easily, we just did one activity that we do, we just started, and I just calmed down. And I could then very quickly get into what I need to talk today. Okay. So the point I'm trying to make here is that when we are using an art form, we generally, even when you go into a therapist, you're anxious. I have people come to me who say, I was very nervous. I was hoping to cover every point and everything. But when they come for arts-based therapy, it's a safe space that has already been created for them. They're able to be there in that moment, and they are not supposed to perform. They're supposed to put what they want onto their through that art form, and there's no judgment, obviously, because this is art for therapy. It is not art for putting up in a museum or something. It's or in an exhibition. It's art for therapy that we are using. So they are able to absolutely freely express whatever they need to onto that in the different media that we use, even music, rhythm. It amazingly it helps and it works, and it brings a person to the present moment. It grounds them to see the reality where as is now for them, and to be able to do it without. So they might be feeling their worst, but they know that this is out of me and it's out there. I'm able to remove it, put it out there, and there is someone who's I'm in a protected space and I can do this freely. There's nobody who's going to judge me on this. That is basically how it starts helping a lot. Where bipolar, similarly, like I said, where bipolar disorder is concerned, I will look at the different aspects, the different characteristics or the patterns that the person is showing and help them break the pattern. Of course, awareness of the client is also very important, because of which it takes a longer period of time. Because when they're in an episode, it gets very difficult. That's when medication and all is only required. But when they are, when we reflect back on an episode, they're able to then that time, start expressing it on their through a story, through music, through a different through art maybe, or even expressing it through their body. Through a certain emotional expression of using the body, about how it was at that time and their journey away from it. So this is just a little bit, I mean, I don't know, there's so much to say that I feel I'm getting a little fragmented in explaining it all at one go. But I would also it would be great to have questions from you all also, and from other people who might be listening in, if there are any. So we could I can explain specifically if there's anything that a person would feel like understanding.
I think I really have to tell you this thing, that while you were asking three of us about the journey and how that one technique, I think it brought a smile on all three of our faces to just know that, okay, this is how it is, and or this is how an individual would feel. And I think another important thing in art based therapy is that the individual does know that you don't have to be an artist to create any art.
Not at all. In fact, I may just add, this metaphor, like she said, pit, it just explained everything how she would feel. She didn't need to say anything more. That pit would be enough to say it. And then the tree, it's just, that you can that's just enough to say. And for all three of us who shared at that point of time, it's just so, just that the metaphors can be themselves very healing. And again, there's, within the session, when there is something that comes up, it's not, we can move away and we can improvise. We do not need to get stuck with this is the only way to do it now. What the client brings up is always paid attention to, and we can move from there. So these are some of the, I can go on and on, so because I just hope it's useful for the people who are listening. That's my concern. So it's.
So, ma'am, since Neha, ma'am, since you've been talking about a lot of different forms of art-based therapy, like there is, you said drama therapy, you said there's drawing and painting that would come under, this thing. Then there's also a different therapy. Is there anything, like differentiating among them, or, what form of art-based therapy has the most evidence, which does not have it yet, something like that, if you can.
I have to very proudly say that each of them, and the reason I'm not even bringing about the researchers, because that would get into a very technical kind of a conversation, but if you go onto the internet, each art form for each kind of difficulty, there is enough data available to see that, let's say someone is having difficulty with concentration, focusing and concentration. So there is focusing and concentration with drama therapy, focusing and concentration with music, with art, and an integration of all expressive arts, as it's called. And there's a lot of data on arts-based therapy, because this people who learn arts-based therapy, who train and learn arts-based therapy, they all have to do a research. They all have to do it with the different populations they work with, and then that is available for people to see that with so and so kind of difficulties, impulse control, which is a major issue where bipolar is concerned. Impulse control and arts-based therapy, the amount of work that has been done, which shows that there's a change, there's a definite change in their patterns, if I may say so, and in their overall mental health. So there is too much data on that. Please go on the net and find out, and you'll be in anything more is ever required in order to share.
With your permission, ma'am, if I can make this as a summary, maybe the clinical aspect would be focusing on the disorder or something, but to make a change in quality of life of the individuals, to reduce their frequency of episodes, and to keep them in a state of normal rhythms of mood. Definitely, these expressive arts and other forms of art will definitely help them, not definitely during acute episodes, but after remission, after they have been stabilized, they can think well, their judgment is intact, and they can learn to aware about their own feelings also, and they can express it in the form of arts also. That will give them a different sense of accomplishment too.
Very well explained, Dr. Rahul. Something which, me being this person who's exuberant all the time, would bring it all in. You've said it very concisely. I would say it with so many words. You've said it with few words. That is exactly how this is useful, and it's really a matter of great joy for me. And I'm a clinical psychologist myself, but that we see a lot of psychiatrists embracing, like people from the community, from the field of mental health, embracing arts-based therapy also as something which is which also adds on to their treatment methods, and it's impactful because it is. So to be able to recognize that becomes very, very helpful for the kind of work that we all do.
So together we can definitely help the individuals to identify if there are any triggers related to mood episodes, to get help with them with medication, psychotherapy, and art-based therapies, and keep them maintaining their life at a stable sense, and they can sail through these ups and downs of this depression. That was the theme we have proposed for this awareness initiative. Thank you, Neha ma'am, for giving us a brief about all these aspects, and thank you, Neha, for sharing the details. I think Dr.
Dr. Rahul and Nehal, whatever you shared has been very, very informative for me also. And it's also been a rehash of reminding me of some of the aspects, and especially some of the therapeutic methods, and all very, very useful. Thank you so much for that.
Thank you, Neha.
We are glad to let you know, all the audience and our panelists, that Symbiosis has come with degree course in mental health. I would ask our SKU head, Dr. Girija ma'am, to give a brief update about that course, and how, because she is the program head for this course, and she has designated all the course curriculum, and that incorporates all the arts and humanities together with the sciences. So that will be a really different course. I would request Dr. Girija ma'am to please share this with our audience and our panelists. And I would also request our IT support team to share the brochure in between on the screens. Thank you.
Thank you, Dr. Rahul. And first of all, thank you, Neha, for joining us today and giving us so much information on arts-based therapy. I purely feel that, mental health is a perfect example where arts and sciences totally come together and can create magic. So no longer education needs to be looked through a single lens where, students categorize subjects into pure sciences or pure arts. I think we are moving towards a place where education will be seen through more multidisciplinary and interdisciplinary lens. And that's what our National Education Policy 2 talks about. And aligning with that, we are launching our BSc in Mental Health program from this academic year, commencing in year 2022-23. It's a 3-year undergraduate degree program in mental health, first of its kind in India, where we are incorporating courses from humanities and social sciences along with courses from pure sciences. In fact, we are incorporating courses from faculty of management, faculty of law, as we see that mental health is contributed by and determined by various factors in our environment, and there are also legalities associated with it. So this is for our viewers. Please do look out for our posts on social media where detailed information about our program is available. And do register now because registrations are open for 12th standard students of all streams. So we are not, even though the program is named BSc, it is open for students from arts, science, and commerce. And the eligibility is simply having 50% marks in your 12 boards. So please do look out and register for a program, and happy to announce this today. Thank you so much.
This is so needed, ma'am. This is lovely. I'm feeling so excited just knowing about this, and I'm going to let people know about it too.
Oh, thank you so much.
It's excellent.
Thanks a lot.
Yeah.
So much, Girija ma'am. I'm pretty sure that our viewers are very excited to, enroll in this course and know more about it. So coming back to the, questions and the questions that our viewers had, we have a few questions that I would, like our panelists to answer. Nehal ma'am, can you, there's a question that says that, okay, I face symptoms of bipolar disorder and want help, but my family thinks that it's only insane people that need therapy and they are put in asylum. So how do I convince them to let me to get, go for therapy? Can you just help us in brief and answer this one?
All right. So there is a lot of stigma that's associated with going to a psychologist. And I think perhaps having an open conversation with your parents is one way to go about it. If you feel that you are not equipped to do so, you can go meet a therapist or a counselor separately, and perhaps they can set up a conversation with your parents to let them know about the kind of issues or symptoms that you've been experiencing, and that going to therapy is extremely normal. It's just like going to a doctor when you have cold. Similarly, you go to a mental health professional if you're experiencing these symptoms. So that's one part. The other part is that if you choose to go to a therapist, there is a clause of confidentiality, meaning that your parents will not know that you're going to a therapist, especially here at Symbiosis. But unless there is a risk to yourself or you are at risk of harming other people. Those are the only two exceptions of confidentiality. Apart from that, the information that you share here with the counselors is completely confidential. Your friends, teachers, directors of your institute, they do not get to know about what's happening unless you consent to it, and the two exceptions that I spoke about before. So having an open conversation definitely helps in destigmatizing mental health and mental illnesses. So I would encourage you to do that. If you're a student of Symbiosis, please drop us an email at mindhelp@siu.edu.in. We would be happy to get in touch with you and set up an appointment with you. This is a service that we offer throughout our campuses in Pune as well as outstation campuses as well. There is a campus counselor located at every location in your institute, and you can reach out to us directly and the counselor will let you know how to proceed. So please do that. I hope that answers your question.
Yeah, thank you so much.
I would like to say that at certain moment, students will have to take onus of their own mental health. Although their parents may not be well versed during their learnings or their times about the mental health perspective or the stresses you are having may not be that par with what the time frames had been for your parents. So any doubt, any queries, please seek help from this our portal mindhelp@siu.edu.in. And it is a free service from our counseling team. We have a psychiatrist also, 2 psychiatrists on our team. We do our teleconsultation also. So all these services are going to be free for the Symbiosis students and faculty. So please take owners of your mental health and just avoid this ambivalence or this conflict that whether to seek help or not help, because that is going to lead you some delay in seeking help and the conditions may deteriorate.
Okay. All right. So we have a lot of other questions as well, but then I would like to tell all our viewers that we would be covering it up in our other social media platforms like Instagram and Facebook, and we'll make sure that we answer all of them. And I think we'll end our session here. And I would like to thank all our wonderful panelists for their time, for the valuable information that you people shared with us, and the lovely viewers who joined us today. Thank you so much, everyone, for your precious time.
Thank you, Simran, for hosting this event, and I thank again Neha Patel ma'am and Nehal for joining this as an event, and thank you, Girija ma'am, for updating us about the new course, which is probably going to change the definition of mental health. Thank you.
Thank you so much. Simran, great job. All right.
You can stop the live.